Good morning, everyone. Let the record show that we have a quorum present, and I'd like to call the Public Accounts Committee to order. And this morning we're going to be dealing with the segregated insurance fund of the Cayman Islands related to the health insurance industry. And we have a witness. Anybody, just on a housekeeping matter, I believe that Mr. Harvey Stevenson is unable to attend the time he was invited.
Yes, okay.
Has he given an alternative time that he could come?
No, he's in cancer treatment.
Okay. I would suggest that it committed in that, because I think there's a medical issue with him. So what I would suggest we do is invite the deputy chairman to come and to fill in the same slot. Because he wasn't supposed to come today, right? It was.
Yes,
Okay, well, we'll fit him in another day, okay? You can bring in the first witness, Mr. Mervyn Connolly.
okay. I swear by Almighty God that the evidence I shall give to this honorable legislative assembly shall be the truth, the whole truth, and nothing but the truth.
Thank you.
I swear by the Almighty God that the evidence that I shall give to this honorable legislative assembly shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Good morning, Mr. Conley and Miss Melissa. I'm trying to remember her surname, but I know her by different names. So I don't want to get into trouble. Thank you all very much for coming. We want to talk today about the segregated insurance fund, and we'd ask each of you that when you answer the first question, just identify yourself by name and title for the record. You only need to do it once.
Sure.
So I guess I'll start it off by asking a more general question of you, Mr. Connolly. In that, can you tell us what was the genesis of this segregated insurance fund, and what is the policy that supports it, and what's it expected to achieve?
Thank you very much, Mr. Chairman. I am Mervyn Connolly, the Superintendent of Health Insurance. In regards to the segregated insurance fund, the purpose for that fund is to help offset the cost of medical care that is provided to the medical indigents.
And it is generated by the number of people that are insured. There's a charge per person insured, or what is the breakdown?
Thank you, Mr. Chairman. Yes, included in the premium rate for the standard health insurance contract, there is a fee of $10 for each individual and $20 for each family plan that is provided through the approved insurers.
So how do I know that you collected your income doesn't identify the numbers? It just says what the total amount received was. How do I know, or what confidence do you have that you are in fact collecting all of the revenue that the insurance companies should be paid? Do you get a submission, and can you verify that each person that has a premium with each company does in fact pay this money?
Thank you, Mr. Chairman. Yes, indeed. First up, we do require on a monthly basis all of the approved insurers to provide the Health Insurance Commission with the number of insured persons that they would have on their books by the 5th of each month. So we have that information that is ongoing. In addition to that, we obviously also obtain on a monthly basis information in regards to the premiums that they have collected. We also conduct site visits to the approved insurers to review those records. And at the end of the fiscal year, the fund is actually audited by the Auditor General's office. But for perhaps more details, if you would allow me, Mr. Chairman, Ms. Melissa Webb, who's the financial accountant and has direct responsibility for collecting those funds and also ensuring that they meet all of the requirements set out under the law, she would be able to provide additional details.
Thank you, Mr. Chairman. Melissa Webb, financial accountant. We do require at the end of the fiscal year that each approved insurer provide us with an audited certificate breaking down the amount of contracts, health insurance contracts, premiums that are collected, and they do on that form tell us how many employees they have insured, how many employees they have employees groups, and then they have it break down under number of insured, the amount of single persons, and the amount of family plans that they have. So the report that we get from them monthly, we do a yearly audit at the end of the year, and we make sure that that information that is reported once it's audited by their auditors, that it's the same amount or the same report that they're reporting to us on a monthly basis in terms of segregated insurance fund, number of plans, and the number of persons that they actually have insured.
Do you have any way, or do you have any interaction with SEMA as to the number that they report to them, to make sure that that's the same with what you're getting?
Yes, we obviously have a good working relationship with SEMA. We meet on a quarterly basis, and I'll be, although most of our discussions is regarded to enforcement and operations of the insurance companies. I think the one difference that we have, we're operating on a fiscal year, and it appears that SEMA's information is really on the calendar year. But by and large, we do certainly share information.
Good morning, Mr. Connolly, and I just want to thank you and your other team member for being here this morning. One, just to give an idea of where my questions will be coming from, it'll be based on the CMA's report primarily, and also from the Auditor General's report that was issued in January 2017 concerning the Cayman Islands health system. One of the things that jumped out, and just looking at the financial statements, we see that based on this, that we're looking at around $4.6 million that were collected in 2016, and just under 4.25 million collected in 2015. And when we look at page 30 of the Auditor General's report concerning the Cayman Islands health system, we see that indigent care is roughly 32.25 million, but is only 4.25 million is actually being collected by this fund, which basically leaves the taxpayers of this country $28 million short. And in terms of caring for indigents, and what really prompted this hearing this morning, at least my support for this hearing, is I've been going through the CMA's report, and I just want to give you from 2011 to 2015, just some numbers so you can have an idea of what we're talking about. In 2011, just looking at page 26 of CMA's annual report, you won't have this information, but you can just make a note, and I can always repeat it back if needs be. It shows that the profit under the healthcare, based on the audited financial statements that were submitted to CMA by the insurance companies, showed a profit of just over $4 million at December 31, 2011. If I look at the December 31, 2012 report, I see a profit of roughly $10.8 million. And then if I go to December 2013, I see a profit again for the L section of roughly $14.3 million. And then if I go to 2014, I see a profit of just a little over $14 million. And then this is one of the primary reasons we're here this morning. And when I go to 2015, I see a profit of $51.5 million. Now, when you consider that between 2011 and 2014, the total profit, as per what was reported in the CMA's report, was $43.1 million, averaging $10.8 million over those 4 years. And then in 2015 alone, I see a $51.5 million profit. And that just coincided with the fact that the taxpayers of this country also had to fork out an additional $28 million to cover indigent care. The committee basically became concerned in terms of what is really happening with healthcare in this country. That in 1 year alone, $51.5 million worth of profit can be reported on health insurance when we're made to believe that this is an unprofitable business, but yet the taxpayers of this country is still stuck with finding, well, technically the full $32 million, because even the $10 a month is being charged to the consumer. You know, it kind of gave us a bit of pause in terms of what is happening. And when we look at the health insurance law and look at the responsibilities of your department and the important role that it plays within the monitoring and management of the health insurance industry within our country, we wanted to kind of understand better, or so at least we can tell the public what exactly is going on with health care in this country. And that is pretty much, so to put everything in a question format now, is that seeing this trend, and this is something that we need to make sure we can arrest, because we can't have these massive profits being reported on health care when you consider the size of our population. And to make matters a little bit more ease, is that I did a quick calculation in terms of looking at the ESO statistics between those people employed between 2011 and 2015. And also, I looked at the total amount of civil servants, just core civil servants, and I deducted that from the employed population. So if I was to look at even the premiums that were written, and again, just bear with me a little bit. In 2015, if I take the total employed less the core civil servants, which will leave me with the public and the SAGCs to some extent, and I even kind of just look at the premiums, the average premium that a person is paying per employed person, just roughly. Between 2011, the number was 4,221 per year. In 2012, it was 4,400 per year. In 2013, it was 4,596 per year. And in 2014, it works out to 4,963 for average over that 4-year period of roughly a little over $4,500 annually per employed person. But then in 2015, using the same analysis, the same number, it jumped to over 6,000 and change per employed person, roughly up by 33.5%. And I mean, just looking at the rough calculation. So when we look at the backdrop of these numbers and these statistics, it leaves us as the committee members and naturally the general public that we represent to ask what is happening, and more importantly, what is your department doing to arrest this, because we don't want this to become a trend. And so that is pretty much the question in all of that. But just to give you the backdrop so you can understand where we're coming from.
Sure. Through you, Mr. Chairman, thank you, Mr. Saunders, for that, again, very, I guess, comprehensive review of the performance of the health insurance industry, over the past, since 2011, 5 years. And you are correct, sir, in making that observation. I think it is also very disconcerting, and for us at the Health Insurance Commission, that we have a situation where it looks year on year, especially over the last 5 years, it's trending that there are significant profits by the insurers. Having said that, from the Commission's perspective, we have 9 approved insurers, and we look very carefully every year at their loss ratio. And it is clear that the premiums that they're collecting has been significantly increasing. And the average loss ratio across the entire industry is about 76% or so. We, meaning the Health Insurance Commission, monitor and regulate the standard health insurance contract. But Mr. Chairman, if you just allow me, I would like to read Section 13 of the Health Insurance Law 2016 revision. And it says, notwithstanding Section 5, nothing in this law shall be construed as preventing any person from concluding with an approved insurer, in addition to the standard health insurance contract, any other contract of health insurance providing for himself, his employees, or his employees' dependents, supplemental health care benefits, or supplemental medical benefits that are in addition to those contained in a standard health insurance contract. And such additional contract may provide that benefits to an employee or the employee's dependents shall be covered under the additional contract for any stated period of time while he is employed or after the employee has retired. So what this says, in essence, is that an employer or an individual can go to an approved insurer and they can purchase any additional plan of benefits, and we refer to them as supplemental benefits. And Mr. Chairman, I would want to say that we are confident at the Health Insurance Commission that we do supervise and regulate the premiums that are collected for the standard health insurance contract. And as a matter of fact, the premium rate for the standard health insurance contract was actuarially determined and that from 2013, and the premium rate for that standard health insurance contract has not changed. The trend also that we're observing is that we have more people who are opting to go for these supplemental plans. In other words, it provides them with additional benefits and better cover. But in doing so, they are then subjecting themselves to the premium rates that could be charged by the approved insurers. In other words, under Section 13 of the law, the Commission, we do not have the authority to really regulate the premium rates for those supplemental plan benefits. We do obviously monitor the information, and we can say to you that based on our observations, it appears to us that year on year for those supplemental plans, the approved insurers are automatically implementing an increase in the premium. There's really very few exceptions where they have really actually maintained the same premium rate over the previous year. But year on year, based on what we observe, they have been increasing those premium rates for those supplemental plans.
Why has the Insurance Commission not advocated to get supervision over those additional plans and put that in the law and remove Section 13? Because Section 13 was obviously put there on behest of the health insurance companies themselves.
Well, Mr. Chairman, what I can say to you is that if you, and I'm sure you're quite aware of this, going back to the previous regulations, they were actually 4 standard plans. And the way the law was set up at the time was that you could purchase any of those 4 standard plans, and those 4 standard plans would be monitored and regulated by the Health Insurance Commission. Unfortunately, in 2013, the 3 plans, higher plans, were taken out, and we are now left with just the one single plan. So, it obviously, there would be some implications, if we restricted the number of plans that the approved insurers would be able to offer, and that would be mainly the impact of choice. But we could sufficiently ensure that those benefit plans were, if I can use the word, rich enough to really meet the needs of, we would suspect, pretty much everyone who's resident here. What it would allow us to do, though, would allow us to actually monitor the premium rates and ensure that we're not seeing the type of trending and the type of experience that is currently being experienced. Of course, from the Commission's point of view, we would certainly need additional resources to ensure that we have the capability to adequately supervise and regulate those additional plans.
Thank you, Mr. Connor. Just looking again at the Auditor General's report on page 22 for the Cayman Islands Health System, and I'm reading point 53. It says, the Health Insurance Law 2013, the Health Insurance Regulations 2013, and the Insurance Law 2010 provide a framework for monitoring and regulating the health insurance industry in the Cayman Islands. The Cayman Islands Monetary Authority is responsible for regulating the insurance industry in the Cayman Islands. This includes licensing, ongoing supervision, and enforcement. The Health Insurance Commission assesses and monitors premium rate, administers the segregated insurance fund, which collects a small monthly contribution from all private plans to help fund health care for indigents, monitors the conduct of approved insurers, resolves complaints, and advises the Minister generally on any matter relating to health insurance, including advice on amendments to the health insurance law and regulations. With this said, recognize that the Minister himself is responsible for policy. The question then, through you, Mr. Chairman, is what is the Health Insurance Commission, what advice is it given to the Ministry, or what is being done to make sure we start arresting this from early? Because like I said, I am really uncomfortable seeing profits averaging what they were averaging before, and then jumping up in 1 year to what it is on the backs of the consumers of this country. I mean, $51.5 million profit in 1 year when you're averaging 10 million or something in the previous 4 years is a little bit too much. So the question then is, what is the HIC, the Health Insurance Commission, doing, or what advice is there now given to the ministry to make sure that we're dealing with this issue like right now, as opposed, and bearing in mind that this is 2015 numbers we're looking at. So I dread to see what maybe 2016 or 2017 numbers would be.
Through you, Mr. Chairman, the Health Insurance Commission, from the perspective of in regards to monitoring and regulating the industry, we certainly investigate complaints in regards to the operations of the health insurance companies, meaning we look at complaints in regards to whether an insured person is being treated fairly in regards to the benefits that they should be receiving under their plan that they have. We certainly look at things like portability of health insurance. We ensure that, you know, if a person is entitled to portability of benefits, that is covered, whether it's under the standard health insurance contract or a supplemental plan. Things like coordination of benefits, etc. So we provide definitely supervision for those type of initiatives. I think where we are not able to do as per Section 13 of the law, we are certainly not regulating the premiums for the many other supplemental plans that are out there. There's one particular insurer, based on information we have, that really and truly they are able to go to an employer and they will tailor the benefits based on what the employer would like to have. Again, a lot of these plans, they have their co-insurance is really very little, and as a result, the premium rates are significantly high for those type of plans. So where you don't have a lot of, you know, co-insurance and deductibles kicking in, it results in a lot of significant increases in the premiums, meaning that the approved insurer is paying for those claims, meaning where you don't have a lot of co-insurance, and as a result, they are then using that claims experience year on year to increase the premium rate. In regards to the recommendations, we believe that going forward, there are going to have to be some amendments to the legislation in regards to the offering. Because as I mentioned earlier, the number of persons that are covered under the SHIC plan, based on the latest trends, is certainly approaching just 20%. So more than 80% of the insured persons are covered under higher plans. So what that is saying to us is that there is definitely some gap there in regards to what the standard health insurance contract is currently doing and providing for insured persons versus the supplemental plans. Having said that, it is clear that if we're going to look at changing any of the legislation, we would want to make sure, again, that whatever schedule of benefits that is provided, that is well thought through, that we have a clear understanding, first of all, on what those schedule of benefits are, what are the implications in regards to how much it will cost, and then how will that be, how will that be implemented?
Just to understand this, Mr. Connolly, am I to believe, or the committee to believe, that for the more than 80% of the people in the private sector that have these plans above the SHIC plan, that we have nothing in place to protect them or to regulate what they're getting? In other words, there's no one looking out. We have nothing under the law that allows us to deal with the issues that they're getting. If they're getting ripped off, we basically have no protections or anything. to deal with it?
Through you, Mr. Chairman, no, I wouldn't exactly phrase it in that way. I think, as I said earlier, if you have a plan of benefits, a supplemental plan of benefits, and you have a complaint against an approved insurer in regards to whether you're getting coverage for those level of benefits, certainly we will investigate that and we will ensure that whatever is required that is properly adhered to. I think what we're saying is that we don't have the authority to regulate the premiums that they charge that particular individual or that particular group for the level of benefits or for that schedule of benefits that they're receiving.
Do you have the authority to ensure that they're getting value for money then? Is that there?
Yes, that would be correct, sir. Yes.
So you have that authority?
We have the authority to say that if this is your schedule of benefits and these are the benefits that are being covered, that when you go to your healthcare provider, that those benefits will be covered by the approved insurer.
Okay, then, but in terms of cost, because here's what I'm trying to drill into. I'm trying to understand, and like I said, this is why we're here today. You're averaging 10 point something million dollars in profit for 4 years. And then it balloons up to 51.5 million. I mean, that money came from the consumers in the country. Mm-hmm. The question then is, at what point does someone look at those numbers and say, wait a minute? And then at the scariest point, to which I'm sorry I didn't get these numbers, but looking back at remembering the budget process we had last year, mm-hmm. and seeing the challenges that Cineco is having. What I suspect, and I think I'm pretty sure I'm correct, is that if we are the private sector cherry picking who they're insuring, and then leaving Cineco / the taxpayers of this country with the people that they don't want, and then bearing in mind that the purpose of insurance is to spread risk. The only risk that is being spread, in essence, is on the taxpayers of the country, and then the insurance companies basically make off like bandits. I mean, anybody would have to admit, you jump from 10 point something million profit to 51.5 million, and then the government is started with indigents and all the uninsurables. Then the question is, where is the risk being managed? Where we are the ones taking the bulk of it, and the private sectors are basically cherry picking and taking off. At some point, the conversation, we need to have that conversation now in terms of what is being done to deal with this, because we cannot have this continue.
Through you, Mr. Chairman, and again, thank you, Mr. Saunders. If I could, though, I think it would not be fair to say that Cineco is really just being left to carry all of the risk. The law was amended in 2013, and all approved insurers are now required to offer health insurance to persons even if they have medical conditions. And I can assure you, sir, that based on the information that is available to the Health Insurance Commission, we know now that all of the other 8 approved insurers are also assuming and taking on risk, meaning persons with various medical conditions. I think prior to 2013, it would be fair to say that, yes, it probably was only Cineco who was really taking on persons with medical conditions. So we believe we have addressed that. I think where we are now is that clearly the standard health insurance contract provides benefits for hospitalization and emergency care. It doesn't really cover significant benefits for outpatient care and dental and vision and that type of thing. And from what we're saying is that even though we've just in 2013 made some adjustments to that basic plan, and again, that is the minimum plan that is required under legislation, and that is the policy of the government, obviously. It appears then that as you've indicated, that we need to have a conversation in regards to the way forward with this, because it is very clear that yes, based on the indicators and based on what we're seeing happening in the marketplace, the cost of health insurance, the cost of health care, overall, and I think we should not disconnect the two, because the cost of health care has also been increasing, and obviously, utilization also has been increasing. So, we need to look at this, and I agree with you that we should be having, a discussion on what it is that we want to do and what is it that we're envisioning going forward. Because when you look at the proliferation of the provision of healthcare services in the Cayman Islands over the last, say, 5 to 10 years, I mean, it's just been, really incredible. And I think it's really great that we have a lot of, great access to very highly skilled professionals. We have access to top-of-the-line technology, but all that also drives up the cost in regards to utilization and the increased use of high-end technology.
Quick question, sorry. Quick question. On average, would you say per annum, how many uninsurable certificates would your office issue?
How many?
Uninsurable, I think there's like a certificate where people are like uninsurable.
Deemed uninsurable?
Yeah.
Over the past year, we've actually only issued one.
Okay.
Yeah. So we, again, we're really requiring the approved insurers to accept persons with medical conditions.
The reason I asked that question, and sorry, Mr. Chairman, is that one of the issues I've always found that I've had with the law is that while it made it mandatory for us to have insurance, it didn't make it mandatory for them to sell it insurance. And what I'm hearing from other people out there is that when they do go to the other insurance companies, to not take them, what they do is charge them a crazy premium in a sense. So they're offering them something. Mm-hmm. They're offering them coverage. But the premium that they're charging them for coverage, I mean, one I heard was about $4,000 a month that someone had said to me, that they were basically being quoted. So as a result, that person then had to go to Cynical. Now, the issue is then, yes, the companies would be compliant because they did offer the person coverage. But then the issue is, at $4,000 a month,
Can afford that.
no one is going to, no one can afford that. You know what I mean? So I think this again is really where the gray area comes in, that they're doing it, but technically they're not doing it because no one will accept it. You know what I mean? And I think the challenge that I'm having, and this is one of the things that came out during the budget process, is that when we looked at Cynical numbers and started analyzing the breakdown of Cynical, it actually turns out that the civil servants were actually subsidizing the folks that retired from out of the private sector. So if to kind of put things in context, you can work from 16 to 65, 49 years in the private sector, and you'd have paid private sector health insurance. And the minute you go to retire, and with no company, well, very few companies in the private sector offering post-healthcare benefits once you retire, then it means then at the time in their life when they're most in need of care, they will get Cynical, where the premium is around $300 and something a month, I think, well, for some cases I've heard. But yet at the same time, when you start looking at what they're paying versus the benefits that they're getting, I mean, when you go and you risk weight those people $300 a month, when in fact it should be probably close to maybe anywhere from $1,000 to $1,500 a month, it means then that it is really being subsidized by the taxpayers and in some cases really the civil servants. You know what I mean? And that for us is really where the issue is. It comes on to that old post-retirement issue where everything is just being dumped onto the taxpayers, and then the private insurers can, of course, fit the $1.5 million profit. You know what I mean? So the question in all of this then, Mr. Connolly, is where it is within your mandate to advise the minister or the ministry in terms of what needs to be done. The question then is, what advice or what changes do you think that we need to make with the regulations or the law to make sure that the taxpayers of this country are no longer subsidizing private sector healthcare to the tune of what we're seeing now?
Through you, Mr. Chairman, and thank you, Mr. Saunders, again for again making some very valid points. I think the way forward, if we're really going to get on top of this, we're really going to have to look at, first of all, what it is we can do in regards to Section 13 of the law. And in addition to that, whether at some point in time we look at the current health insurance regime and whether, because we currently have, 9 approved insurers for a population of less than 65,000. And I think clearly where there is the ability for the approved insurers to really, I guess, utilize what is available to them in regards to offering supplemental plans with no real supervision in regards to the premiums that they're collecting for those. I think that is definitely something that is disconcerting. And when we take into consideration that I believe that the Commission is doing a good job, if I can say that, in regards to requiring employers to provide health insurance for their employees. I think, the point is now we want it to be certainly affordable and sustainable. And I think, unless we really take some action going forward, I think what we're doing right now is really not going to work. I agree with you. It is reaching a point where it is really not affordable. And certainly, the other concern would be for it to be sustainable going forward.
Sorry, just one, sorry, Mr. Chairman, I really, really apologize. I'm looking at, no, I know you have a question to ask, and I feel like that's fine. I'm looking at page 55 of the Auditor General's report concerning the Health Insurance Commission, and it says, the HIC has a 9-member board consisting of the Chief Officer of the Ministry responsible for health insurance, the Chief Medical Officer, the Superintendent of Health Insurance, 5 members appointed by the Governor from amongst persons experienced in the areas of health, health insurance, finance, including accounting, and regulation of insurance, and 1 member of the public who is not experienced in any of these areas. As of 2016, the HIC has a staff of 6, including 3 health insurance inspectors. My question is this. You have a department of 6 with 3 health insurance inspectors. There's a 9-member board. In other words, your board is bigger than your entire department. Are we to, in essence, believe that 3 health insurance inspectors is sufficient to manage these 9 providers that are providing roughly 40,000 insurance, covering roughly, 40,000 employees or thereabouts and their dependents?
Through you, Mr. Chairman. Again, I think with the resources that is available to my office, I think we're maximizing what we can do. Clearly, if we had additional resources, there's no doubt that we could do even more. But I want to make it abundantly clear that we're talking about really the standard health insurance contract. If the policy is that we're going to certainly increase the responsibility and the authority to regulate and supervise the health insurance industry, as I mentioned earlier, we would definitely, most definitely require additional resources. There's no way that as superintendent that I could undertake additional responsibilities with the current level of staffing that is available to us.
What would be your ideal vision of what the HIC should look like and in terms of, and what staffing do you think would be needed? Because clearly this is something that's very important and we can't afford for it to slip. So if you can tell us that, then we'll make the necessary lobbying and changes that we would need in terms of putting the framework in place to protect the consumers and the taxpayers of this country.
Sure. Through you, Mr. Chairman, again, Mr. Saunders, thank you for that. Obviously, this is a big and, a significant question that you've raised, but I'll certainly give my personal opinion. So, moving forward, it appears that we're going to have to address the issues of these other supplemental plans and benefits. And I can say to you, if we allow the approved insurers to offer as many plans and as many, scheduler benefits as they would want to offer, that would be significant. So I think the first amendment would be that we would have to look at how many plans we would be requiring approved insurers to offer. Based on that, obviously, we would then be able to determine better what is required in regards to monitoring and regulating those plans. So if we go back to the previous model where there were 4 plans, I would additionally want maybe a couple of inspectors, but I would also want some actuarial support where we can really go in and do more work, more comprehensive work and analyzing the statements and the performance of the health insurance companies. To some extent, we have made some progress over the past year, and I'm sure you would recall that the amendment to the health insurance law in 2017 now allows the Health Insurance Commission to, first of all approved insurers have to demonstrate to the Commission that one, they have a Class A license to conduct domestic business local in the Cayman Islands. They have to have a letter of good standing from SEMA. We also require them to renew that approved insurer certificate on an annual basis. So we've added some additional conditions in for all of the approved insurers to meet so that they'll be able to operate. And obviously, on an annual basis, we can make decisions about their performance in regards to how they're conducting their business. But I think what we really want to see, Ryan, as the point you're raising in regards to how well they're doing, we're going to have to seriously look at those supplemental plans and make some decisions in regards to the premium rates that they're charging. Because clearly, I think whether you're looking at SEMA's numbers and their reports, or whether you're looking at, the numbers from the Health Insurance Commission, it's clear that, they are doing quite well. And based again on information that we have at the Commission, it is mainly through the supplemental plans.
I have a couple of follow-up questions. The 2013 changes, which went from 4 plans to 3 plans, to 1, from 3 to 1, was that a recommendation from the Health Insurance Commission, or was that a request from the industry?
No, I can say with certainty it was not a recommendation from the Health Insurance Commission, and it certainly was not a recommendation from the health industry. I think what was felt was that the 3 other plans were on the books, but they were really never enforced. And I want to make that point clear, that even though they were on the books going back to 2000, they were really never implemented and enforced. And so a decision was taken that since they weren't being enforced, that we would just go with that enhanced SHIC plan that was implemented in 2013.
How many times has, I think you call it the Charge X, the list of and prices that the healthcare providers can charge, how many times has that been increased during this same period of 5 years?
Yeah, thank you, Mr. Chairman. So we have what we would want to refer to as the usual customer and reasonable fees for the Cayman Islands, again, which is reviewed and maintained by the Health Insurance Commission. It has not changed actually since 2005. But I also want to make very clear that the healthcare providers are not obligated under the law to charge those fees. A healthcare provider can charge fees that is in excess of those standard health insurance fees. What we're requiring the approved insurer to pay at least to that level. They cannot pay the healthcare provider less.
Except in the case of the HSA, who collect less, according to evidence they've given us. That they are now contemplating raising their fees to match the Charge Act. So they were obviously charging less before.
And Mr. Chairman, again, that would be a decision of the HSA and the management of the HSA.
For them, what you just said, it's illegal actually.
There's certainly, well, I wouldn't say it's illegal, but certainly we feel that that published fee is usual, custom, and reasonable.
Okay. How does policy flow from the Health Insurance Commission? Does the Health Insurance Commission on a regular basis make policy recommendations to the ministry, or is it that the ministry, it only comes one way, from the ministry down to the Health Insurance Commission?
Thank you, Mr. Chairman. No, the Health Insurance Commission does make recommendations to the ministry. And, again, certainly in regards to amendments to the law, etc., we do make recommendations to the ministry.
Getting back to the customer and user charges, during the time that these premiums were increased by the health insurance industry, those charges were not increased.
That's correct.
No.
Those usually were
And
not
it is
increased.
fair to say that all services provided, even supplementary benefits beyond the SHIC plan, are covered in that Charge Act.
That would be fair to say, yes, Mr. Chairman.
So I think it's important that the public get a real view of this health insurance industry, that we are constantly bombarded that they're not making any money and they need to increase premiums. I'm going to quote some numbers from the CIMA annual report 2015-16, which to me are alarming. The direct premiums collected by the industry locally is 245,349,000. The assumed premiums are 574,000. The ceded premiums, 675,000. The ceded premiums is 30,195,000. And I would assume that is reinsurance. Like, Chris? That would be the reinsurance, what they reinsure. So the total underwriting income, when you take the reinsurance premiums of the 30 million from the 245 million, is 215 million. Their amount that the claims that they pay out is $124,911,000. Change in reported outstanding claims is $17,661,000. Change in IBNR, I'm not sure what that is 9,000, which leaves a total payout of $142,563,000,000. Then they have acquisition and general expenses, which I assume is their administrative expenses, running their offices and whatnot, is $21,743,000, which gives a total underwriting expense of $164,306,000 to give a total underwriting, well, they call it income, but I'm going to put the word profit there, of $51,519,000. And does that kind of correspond with the numbers that they submit to you?
Through you, Mr. Chairman, again, we actually are looking at the fiscal year performance, but by and large, I would say that the if you want to put the profit in there, seems to be, not exactly the same, but certainly it is close enough that we could agree that they're doing quite well.
And out of that, right, this deferral, this charge that we put on individuals and families of what was $10
$10 per individual and $20 per family.
generates 4.5 million.
That is correct.
And that is, this money now is supposed to fund indigent health care in the Cayman Islands.
Well, I think that was the intent, but clearly there's a significant gap. So we're used to using the word help offset the cost of medical care for the indigents.
The other question is, was the original $10, because I think it will start off at 5 and 10, right?
That's correct.
Was that original $5 and $10 for indigent people, or was it for high-risk people that they would not, that the government had to cover because they wouldn't insure them?
Yeah, it was really intended for the medical indigent program.
Okay.
Yeah, and of course, some persons who have significant medical conditions could end up in that medical indigent program.
How does the government or the Health Insurance Commission arrive at the $10 per person and $20 per family in relation to a $50 million profit?
Yes, so Mr. Chairman, obviously if we had looked at what government was expending on the cost of the medical indigent program, then the contributions would have had to be significantly increased. The concern was that if we did that, it would also increase the premium rate for the cost of the premiums. So I think the commission, obviously, our first intent was, well, if it's costing government $24 million, then we need to make the adjustments accordingly. But after certain discussion, with the ministry, I think, we felt that we still didn't want to make the premiums unaffordable, because if we had added that, particular fee to the premium rate, it would have been significantly increased.
What statutory authority does health insurance companies use to stop insurance people at 60?
Mr. Chairman, at this point in time, the insurance company, that would be illegal under the current legislation. The law was amended in 2013 that an approved insurer cannot deny an individual cover. The individual is entitled to cover. Now, the employer, upon them reaching the retirement age, can allow them to remain and they could continue to cover. But the insurance company cannot be the one that is actually refusing and providing with the cover.
What statutory support is there for any employer to say, I am not employing you? Where can I find a retirement age established in law in Cayman?
I think except for the government pension plan, I think there is really not an established retirement.
There is no retirement age ever registered in the pension legislation. It was always the point at which you stop paying premium health, stop paying pension, but it didn't say what it didn't use the word retirement age.
Yes, and I think that's a good point that you raise. Yes.
But the industry is allowed, if they are going to insure somebody over that age, to come to the health insurance and submit a fee, which the Health Insurance Commission can approve or deny, extra, beyond the standard charge for the same SHIC plan at a certain age, right?
That is correct. Only if they have a pre-existing medical condition.
Well, I don't know anybody in Cayman at 60 that don't have a pre-existing medical condition.
Yeah. Yeah, well, we do. We do have some that are pretty healthy, but I take the point that you make that, that is the time when you're probably going to come down with something, whether it's hypertension or high cholesterol or something. But again, the commission do monitor that very closely, and we ensure that whatever that increase is that is what would be allowed for any application coming from any approved insurer. So it is standardized.
So based on the evidence you've given to us, all an insurance company needs to do to avoid your scrutiny on their premium is to add one benefit to the SHIC plan, irregardless of how insignificant it is. In other words, I think the SHIC plan is $100 a year for outpatient medication.
$200.
$200 a year.
Yeah.
So if they offer $225 as an outpatient medication, they would then be removed from your scrutiny as to the premium that they charge.
Mr. Chairman, you've hit the mark there.
No, I wanted people to understand what's going on here, because none of this is by chance.
Yeah.
This is carefully orchestrated by the industry.
That would be correct, sir, that they only have to make any amendments to that
So you
SHIC
could,
plan.
for $25 a year more in prescription outpatient allowances, any health insurance company could add $100 a month to the premium, and you could do nothing about it.
That would be correct, sir.
What is to prevent the Health Insurance Commission from actuarially evaluating what each of those additional benefits could be and what the charge should be for that benefit?
There's really nothing that prevents us to do it, except that
The law.
obviously, yeah, exactly. We wouldn't have the authority to then say, based on our actual report.
But it
this
is
not-
it is actuarially possible
That's correct, sir.
to
Yes.
determine if you want to include dentistry, if you want to
Vision.
include eyes, if you want to go to $500 a month. They could do it on a allowance, outpatient allowance, incrementally, right? And a simple amendment to the law, to Section 13, would give you the authority to control the premiums that they are charging for those additional benefits.
That would be correct, sir. Absolutely. Of course, we would need some additional resources.
No, I will. But granted. So, but the way the law is now, as I understand it, once they make any little change to that SHIC plan, the premium is outside the remit of the Health Insurance Commission.
It's outside.
The
of
only thing that you can then do is, if I agreed to pay the extra premium for the $25 per year more in medicine, and the insurance company stopped at $200, you could arbitrate that they had to give me the $25 additional benefit.
Exactly, sir.
But I would
That is
probably have to pay for it first and then get it refunded later on, right? I actually a question that is a little bit outside your account right now, right? And if you don't have to answer it, you don't want. But there is an effort in the current in public to introduce an over 65 or over 60 health insurance SHIC plan. Given the current industry that we're in, because I don't subscribe to what I've heard your chairman say, that old people don't get pregnant, so they shouldn't be paid for pregnancy, right? Because the whole concept of health insurance is just spread the risk across all age groups, which is what the actuaries do in calculating it. And the younger people pay a little more, so the older people can pay a little less. What would you anticipate a premium for a SHIC plan for people over 60 is likely to be? Even if it is actuarially determined.
Yeah. So, Mr. Chairman, if I can just go back then to this, the feasibility study. I think it would be fair to say that in the Auditor General's report in 2016, there was reference made to persons who were retiring, whether that was 55, 60, or 65. The difficulties, first of all, that they were having to access health insurance, for their type of benefits and the type of needs that they would have at that age. And not only that, the access to it, but the affordability, based on, being on a fixed income. So the Commission took this initiative to conduct a study, first of all, to get a better understanding in regards to what are the concerns coming in from the general public at large in regards to coverage after you retire. And then the second point we want to have a better understanding is, what would a schedule of benefit look like? Would it be a plan that would be covering certain additional outpatient benefits, certainly prescription medications, certainly things like home health care, that type of thing? As it is right now, there's no such benefit plan that we're aware of that is out there. So if we got the feedback and we had a pretty good idea that these are type of benefits, this is the scheduled benefits that would be applicable to persons upon reaching that age, then we would then be able to go out to see how best we could fund that particular plan. It may mean, and I think the Honourable Minister has indicated already that he is particularly concerned about access to health care for children and older persons. So depending on what that schedule of benefits looks like, obviously we could have it actuarially reviewed and a premium rate determined for that particular plan. But at this point in time, we don't have that information which would have to inform us. So I think this feasibility study, will give us what I believe will be valuable information going forward. Now, whether a policy will be determined on how to utilize the information that is going to be provided, again, I think we'll have to see where that goes. But I think right now we want to have really good evidence in regards to what is the extent of the problem, how significant it is. I mean, I believe that it is a problem, and I suspect it is not going to get any better because obviously the population we have an aging population. But having said that, the premium rate, as you said, we would definitely expect it to be significantly higher than the premium rate that we have for the standard health insurance contract. So, and again, we want healthcare to be accessible, we want it to be affordable, and we want it to be sustainable. So, again, with that in mind, I think we definitely need to make sure that we have good information to make any decisions that we're going to be taking going forward.
But so are you asking the public to assist you in determining what benefits that age group require?
That is correct, sir. There was a survey.
But the simple answer is that age group need to be covered for all sicknesses. Because I'm not one of these that believes that the Charge X and all of that, which is just, my view, was only created to make people either really trying to control things when they weren't controlling anything, right? That, because when you find that out, right, because it's almost impossible for them to tell you what they're going to need. Because it depends on, what their underlying sickness is, whether they're suffering from hypertension or diabetes or both, right? So are you going then to go to the other spectrum as well and say, well, do we allow the people from 18 to 30 to prescribe a separate sick plan for them because they don't need any benefits unless they get in an accident, because we don't have a lot of the kind of indigenous diseases that affect that age group, because our immunization programs and things, our public health is very good. I'm old school. You know what my position is that all of this is what I call birds flapping, and there ain't no birds gonna fly. Wings flapping, and there ain't no birds intended to even fly, because where is the funds going to come for this age group to pay this additional premium when the evidence before this Legislative Assembly at budget time, when you look at the millions and millions that government provides in what it is, 7 or 8 various subheads to assist these people, because they can't pay the premiums that exist now for a shake plan.
Yeah, so again, I think hopefully this study will definitely provide us with information that will help guide our decision. And in regards to the point that you were making about they would require everything, and that would probably be true, but again, it would be to what extent.
But isn't the whole isn't the whole concept of health insurance that those who are young, who actuarially are unlikely to have high benefit claims, pay more than actually be determined based on their claims ratio and
Yes.
their premium, so that those at the high end, right, will pay less, because those at the high end originally paid down here and didn't get no claim too, right? Because it's a progressive thing.
Mr. Chairman, I take the point that you're making, but if I could make one observation, that we got to take into consideration that we're operating in a relatively small market, less than 65,000 persons. Really and truly, that is really not the size of a large group, in the U.S. and other places. So the idea of, having the pool where you can spread the risk, meaning that those persons who are younger, not having too many claims being filed, that they would help offset the cost for those who are obviously incurring additional risk when they get older. But because of the size of the population, it kind of throws it off a little bit. And it's very clear, and I think it's fair to say that we, meaning the Commission, the number of complaints that we receive from persons who are reaching and upon retirement, and their difficulties that they're experiencing, it is a problem. Again, I'm not saying that we have the answer for it, but I think it is a problem that's not going to go away, and I think we really need to take a good look at it to see what it is, if there's anything that we could do. Let's just use the example of medications. We know right now there are a lot of seniors, who are requiring medications because of diabetes, hypertension, cholesterol, etc. And those medications, whether you're getting it from the HSA's pharmacy or you're going to a private sector pharmacy, it is certainly not cheap. It's costly. So maybe one of the things we could do, we could look at coming up with a national formulary. I'm just using this as an example, where we could, set up a national formulary and working with PAHO and maybe WHO, come up with a way of procuring medications, especially for these type of non-communicable diseases, and really make them affordable toward the general public at relatively low cost. So again, I believe that we are unique I think we're going to have to be creative. I think we're going to have to be innovative in regards to finding solutions to our challenges. I don't think we can just go and think that we're going to find something somewhere that we can just borrow and it's going to solve all of our problems in regards to health care, access to health care, affordability of health care, and having it sustainable. I think it's really going to require us, all of us, sitting down and really listening to each other and understanding what the challenges are and coming up with, I believe, solutions. I think we can do this if we put our heads and our shoulders to it.
But I think we have to admit that staring us in the face is that we had health insurance reintroduced in 1998, right? So that's what, 20, come on, Mr. No, more than that, man. 1988 to today, got more than 20? Okay, right. 20 years, it has gotten worse every year with this multiple providers of health insurance. Is in getting to the decision to go to this survey, did the Health Insurance Commission give any consideration to going to a single payer for the coverage, not for the provision, but for the coverage of health insurance? Because the industry has always argued that they have to charge high premiums because it's a small group. Well, their claims here defeat that argument completely.
Yeah. Again, I think we want to see what the study is going to reveal, and I think right now, I think there's really no firm policy decision on the way forward. I think we really want to see the information that is coming back, and I think after that, obviously, we're going to share the results of the study with I'm sure the general public and and the LA and everyone, so that we'll all have that information available to us. So I think once we get that, I think we'll have a better idea on. But I take the point that you're making in regards to setting up the single payer.
Getting back to the actual fund, how is this 4.5 million dispensed? Is it dispensed to individual people, or is it given to the ministry or the Health Services Authority on some kind of quarterly, monthly release? And how do you know that it's going to indigent people?
Mr. Chairman, the funds that we're collecting definitely goes to the Ministry of Health, and certainly I'll ask the financial accountant to speak to how that is exactly managed. But how it's actually set up is that Cineco is responsible for managing that medical indigent program. So they review the claims that comes in from the various healthcare providers in regards to services provided to those patients. But the way it is done, that is really only an administrative service. The Ministry of Health, through the Ministry of Health, through government obviously, they pay directly for the cost of the care provided to those medical indigent persons. But if you would allow me, I would ask Ms. Webb to perhaps expand on it a little bit more.
Thank you, Mr. Chair, for that. As the Superintendent, Mr. Conley, just said, that's exactly how it's done. The funds are in general revenue for a ministry, and they access and disperse through their accounts. So everything is done at a CFO level in the ministry.
So when you send it to the ministry puts it in general revenue, or does it remain segregated at the ministry, and Cineco submit claims to that fund for it to be dispensed to Cineco, or does any of it go directly to the HSA?
Once the claim is submitted through Cineco, the ministry would then make the payments to the HSA. That's my understanding.
And that's done on an individual indigent claim. In other words, if I go to the hospital and I say I'm indigent, what happens?
Again, Mr. Chairman, perhaps I should make this point that initially the fund was set up to be truly a segregated fund. And it was intended, I believe, for the commission to have responsibility not only for the collection, but also for the payments that would be made going out of that fund. But because it is considered, I believe, course of revenue, it goes into the general revenues, and then the ministry makes the payments. But to the best of my knowledge, the ministry does receive, certainly the claims for services provided to these indigents, and,
So
and they pay it accordingly.
In theory then, if I went to the HSA and I said I'm indigent, they would do, well, I guess they would ask me certain simple questions, one of which should be, are you Caymanian? Should be the first question. And you produce certain evidence, I guess, that I don't have any income, so therefore I am indigent, or my expenses far exceed my income and I'm therefore indigent. They would then render the services to me as a patient, as an indigent patient, and claim from the ministry through Seneco that cost.
If I can just add one step, one precursor to that. For you to become a medical indigent, you have to go through a means test.
Right.
Identified through the Department of Children and Family Services and assessed by
NAU, I think it is now.
by the Needs Assessment Unit.
Yeah.
And then once you identify that information, that particular individual, the name of that individual is sent to us, meaning the Health Insurance Commission. We have a system called the National Health Insurance System, and that person would be entered into that system. So that is accessible by Seneco and the HSA. So when you go to the HSA as a medical indigent program, they would check to see that indeed you are. And if you are, then you would get your service.
Why you say that? Why you say that? What that name of that system is?
They refer to the database as National Health Insurance.
No, that's a good name because that's where we're gonna wind up. But so you have to be certified by NAU.
That's correct, sir.
But why is that information coming to you if you're paying the fund in bulk to the ministry?
No, we only, the database to ensure that these persons are the persons who are eligible for that benefits, we maintain that database. The indigent database.
And Seneco has access to that, and HSA has access to it,
That's correct, sir.
and the ministry.
And the ministry, yes, would also.
Okay. Do you require any report back from the ministry after you, let's say you gave it to them on a quarterly basis, so you gave them 1.25 million. Do you require any accounting back to you as to how that 1.25 million was spent, or can you determine that from your database?
Mr. Chairman, we, prior to 2013, when the law was amended, the Health Insurance Commission law, to really look at how the funds were being dispersed, we made an adjustment in the Health Insurance Commission law to reflect what was really happening on the ground. That our responsibility, meaning the Health Insurance Commission responsibility, ends at ensuring that we collect the proper amount of monies from the approved insurers. And once it goes into that account, that is where the responsibility of the Health Insurance Commission ends.
So you don't get any report back?
We don't get any report back at this point in time.
Any other questions?
Mr. Chairman, through you. With all of our concerns that we have addressed today to the witness, when can we expect you to come back once you've gone to your commission with how these concerns are going to be rectified? Because basically we have a lot of concerns here with regard to the whole insurance industry and how they are treating our indigent people and the high premiums and all the other concerns. Can you give us some sort of time frame as to when some of these concerns will be addressed? Thank you.
through you, Mr. Chairman, I certainly would like to give the commitment that I will ensure that the Health Insurance Commission Board is aware of the concerns expressed at this hearing today. Obviously, the board will then have to consider and perhaps, require some additional review and consider the matter in greater depth. The matter would then have to be, we'd have to make a recommendation to the minister, to the Honorable Minister, in regards to the matter. And as much as I would like to give you an undertaking in regards to how long it would take, I think I'm really not in a position to say that, but I can give you the undertaking that in my position as Superintendent of Health Insurance, that I will ensure that the Health Insurance Commission Board is aware of the concerns and certainly the discussions here today.
Mr. Chairman, this is my first term sitting on the PAC. And the official Auditor General's report, it says, ensuring quality health care and a healthy population. When you turn, Mr. Chair, to page 22, it says, in brackets, the performance of the Cayman Islands Health Service System is not known, and accountability to the Legislative Assembly and the public cannot be rendered. Mr. Chairman, it is clear that the Ministry of Health has fallen asleep once again at the wheel. After listening and hearing these questions today, it leaves me no alternative but to simply ask a question. Can you tell us where we are with the disciplinary action with this same chief officer that's responsible here once again? Yes, sir. Where are we with the position with the disciplinary action that was posted before this House? Because once again, it's obvious that the same chief officer has fallen asleep.
Well, we tabled, well, I guess we can excuse them in the meantime. Thank you. You have any more questions of Mr. Conley? No? Okay, Mr. Conley. Thank you very much, and Melissa, thank you both for coming.
Thank you, Mr. Chairman.
We appreciate the information you gave us.
Sure. Thank you, sir.
Thank you, Mr. Chairman.
Mr. Bush, to answer your question, well, you and the public would be aware that in a report that we tabled in February, we made certain recommendations and requested the Deputy Governor to deal with the matter of the chief officer in the Ministry of Health, as opposed to us taking the route of going for a contempt of the Legislative Assembly. I corresponded with the Deputy Governor a week ago and asked if he could give me a report as to what was happening. His response to me was that he is currently dealing with it. The delay was as a result of him having to act as governor in the interim period between the last governor leaving and the present governor coming, which was a couple of months, I think it was. But that he would be dealing with the matter. we're not, we didn't go as far as to make a recommendation as to what disciplinary action he should take. And I will tell you that the notion to inquire as to the progress was a response to me seeing in the press that the individual had been promoted to deputy governor in the interim period, acting deputy governor while he acted as governor. I think the 90 days, which is required under, which is prescribed under standing order for government to respond in the government minute, will actually expire prior to the next meeting of the Legislative Assembly, which is scheduled for the 6th of June, I believe it is. So I would expect that the government would be prepared during that sitting, that meeting, to lay the government minute in response to those two outstanding reports from the Public Accounts Committee. And in that minute would have to be part of that, would how I would hope would contain the response to our requests for him to take disciplinary action. We also have the situation where there are two other reports that were tabled in October, to which the government has not yet tabled their government minute because the period between when they were tabled in October and the February meeting had not exceeded the 90 days. And the government doesn't read the fact that it says within 90 days. They think that means, you know, that they have the 90 days to report. So we'll wait and see. We have reserved, as you will recall, under the report that we tabled, the right to exercise what the standing orders of the Legislative Assembly allows us to do in a situation where we find witnesses in that position. That's the best answer I can give right now. We'll take our lunch break, and the next witness is scheduled to come in at 1 o'clock, 1:30. So we'll come back at 1:30. Thank you all very much.